right. Good evening, everyone. I know some people are still in the lobby and still joining. It's now exactly 18 hours to the dot, and that means this is the starting time for yet another Thursday evening webinar sponsored by Clinix Health Group. And these webinars, as you know, they are all for free to the attendees. Thanks to the Clinix Health Group company for sponsoring them, improving sharing of knowledge across the healthcare industry. We really appreciate it. And we have about 240 people in the meeting now. I think the others will join us as I do just introductory remarks. I think it's just to do the house rules, because we've realized that although we've got a lot of repeat attendees, which we love very much, we always have new ones. So there are always people who are joining in for the first time. And I think just to say, yes, the webinars are registered with the Health Professions Council for CPD points allocation to the speaker and to the attendees as well. So both the speaker and the attendees of these webinars will be allocated CPD points. And provided you registered yourself, you did not get the Zoom link second hand or third hand. So you should do the registration. It takes only about 2 minutes to register on our invitation poster, and you put in your HPCSA registration number, your HPCSA registration. I need to stress that because people still put in their BHF practice number, and that doesn't work. Unfortunately, you end up not being recognized as an attendee by HPCSA because they take the list of attendees almost automatically from our attendance list. So, and everything is electronic, and they can see who logged in and for how long. So if you log in for 5 minutes, you log out, we don't guarantee that you'll get CPD points. So we encourage people to log in till the end, if possible. And you need to register anytime before the webinar. So there's no deadline, but obviously we've got a limit of number. We can go up to 1,000 attendees. We now have 361. Welcome to you all. During the speaker's presentation, you will not be able to unmute yourself. You will be muted, but please do, if you've got any question or comments, don't keep it until, otherwise you'll forget. Don't keep it until question and answer session that will follow the speaker's presentation. You can write it in the box, in the chat box. Type it in the chat box, your question, your comments, and then the speaker will attend to them at the end of his presentation. Today we've got none other than Dr. Dennis Maluleka. Dr. Maluleka is a renowned obstetrician gynecologist. He works with us in Clinix Health Group in one of the flagship hospitals of Clinix Health Group, Clinix Tepotemba, private hospital, as a gynecologist. And he got his MBCHB from an MEd from University of Pretoria, and he got his FCOG from the Colleges of Medicine of South Africa. He also had a diploma, I think before then, in obstetrics, also from the Colleges of Medicine of South Africa. His main interest, Dr. Maluleka's main interest in obstetrics and gynecology is high-risk pregnancies, postpartum care. He's keen on that. He enjoys doing reproductive health in general, minimally invasive gynecological procedures, but also the early detection of gynecological cancers. is known to everyone as a very amiable, approachable man, for his approachable manners, and he's also patient-focused, and people like him. Not only his patients, but all of us like Dr. Maluleka a lot. It's a pity that he's having a problem with his camera, but if he sorts it out, I'm sure he'll put his camera on during your presentation, Dr. Maluleka. I'm going to hand over to you. Your presentation is on the screen, and you are going to talk about approaches to abnormal uterine bleeding according to age. I think that's a very important and very common problem. And it has been for many years, abnormal uterine bleeding. And I'm glad that you've chosen this particular topic. Over to you, Dr. Maluleka. I'll mute yourself and hand over to you until you are done. All the best.
Thank you. Thank you, Dr. Kinosi. And I would love to take this opportunity first and foremost to thank Dr. Kinosi, Dr. Shinas, and the Clinix team for giving me this opportunity to come and speak to you about this such an important topic, which is abnormal uterine bleeding. Thank you for the introduction. I just wanted to add on what you have introduced me on. Yes, I've started in Clinix. I'm the new obstetrician and gynae there. I don't work there alone. I work with my wife, who's also a gynae. So yes, we started there, and we are looking forward to working with the team and everyone at Clinix. So today we chose this topic because, like you've said, it's one of the commonest presentation. Majority of the time when a patient comes to a clinic or to a gynae visit is because they've got a worrisome bleeding that they are not so sure of. So we chose to approach it according to age, because that will actually give us a clear understanding and a clear guideline as to what can you do when you've got a patient who's in front of you, who's younger or who's older or who's of reproductive age for that matter. So in terms of introduction, of course, we are going to start with what abnormal uterine bleeding is. We can't discuss anything without knowing its definition. So it is known that it's an irregularities in menstrual cycle, which involved four main things, which is the frequency, the regularity, the duration, and the period. So of note is that you must make sure that all these things are happening outside of pregnancy. So any patient that will present to you with all these irregularities and of reproductive age, you must always rule out pregnancy. Like I said, the commonest presenting symptom in a gynae unit, and then problems in terms of the causes, they can be local or systemic causes depending on what the patient is presenting with. So a study that was done in United States, it was a survey which was looking at the presentation of abnormal uterine bleed. They did a survey in women aged between 18 and 50, and they've actually found that the prevalence of this abnormal uterine bleed was about 53 per 1,000 women. And when we look at us in the sub-Saharan Africa, the prevalence is therefore very high, with about 15 to 30% of patients presenting with abnormal uterine bleed. So before we understand or know abnormal uterine bleed, we must know what is normal. Because when you know what is normal, you will be able to understand or to tell when the patient presents with an abnormality. So what is reproductive age? WHO says that the reproductive age is ages between 15 and 49. And then in terms of the frequency of the menses, the normal frequency is between 24 and 38 days. And then in terms of regularity, this is, the duration. The duration of menses should be between 3 and 7 to 9, depending on which textbook you are using. And then the flow or the volume is determined by the number of pads that the patient used during a menses. They say a fully soaked pad carries about 15 mils of menstrual blood. So for you to determine the volume or the flow thereof, you will have to check with the patient how many times she changes the pad, and you multiply that by 15. That will give you the total amount of the bleed per cycle. And they say more than 80 mils per cycle is determined or is known as abnormal uterine bleed. So how do we classify this abnormal uterine bleed? So it can be classified as acute or chronic non-gestational abnormal uterine bleeding, whereby acute one usually is a patient that comes with a recent onset of active bleeding. They can be or might not be hemodynamically unstable, and that bleeding is occurring within 6 months of presentation. And if the patient comes after 6 months of that bleeding, it is said to be a chronic abnormal uterine bleed. So FIGO will further classify it as the commonest palm coin. This is the language that we should use when we see patient with abnormal uterine bleed. It also guides you in terms of the causes, because the palm represent structural causes, whereas the coin represent non-structural causes. So the structural causes, as you can see on your screen, we've got polyps as represented by P, and adenomyosis as represented by A, and leiomyomata, which are fibroids, and also malignance. So these structural causes are those things that you can prove with imaging. So when a patient comes and they've got a structural cause of abnormal bleed, you can prove it with an image like an ultrasound or an MRI. And then the non-structural ones are those that you need to do bloods to see with the patient, or just based on the history that the patient is presenting with. In terms of the approach, which is the topic for the day, like I said, WHO, ARCOG, and then RCOG, they all recommend that we use the mnemonic palm coin in terms of assessment of and classification, and also classifying the causes of abnormal uterine bleeding, where palm is the structural causes and can be proven by histology or imaging. And then coin is those that you definitely cannot rely on imaging or histopathology to determine. So we'll start off with our first age. Like I said, we're going to approach it according to age. We'll start with children. So for children, the causes are different from adolescents and also adults. Vaginal bleeding that will occur within the first 2 weeks of life, it is known as a physiological bleed, is because of the withdrawal of hormones from the mother, and that is said to be a physiological one and is not harmful. So when a patient has got that or they present with that kind of bleed, the main issue there is just to reassure the mother, and then you can treat as such. And any bleeding that comes after 2 weeks of birth, it's always and always abnormal. You need to look for the cause of that bleed. So in the following diagram, we're going to be looking at the things you need to look out for a patient that will come at this age with abnormal bleed. Like we said, the neonate, if they come with abnormal bleed or mucoid bloody discharge, it's a neonatal withdrawal bleed. So for those ones, you don't really do anything. However, you need to examine their vulva. If their vulva is abnormal, then you must also always look for things like trauma, vulvovaginitis, genital warts, urethral prolapse, and Lynchian sclerosis. It is also a very common thing that in this age group, some can actually be presenting with sexual assault. So you must always explore that part. Don't just say this is the abnormal uterine bleed and you find some trauma on the vulva and you leave it at that. So you must always rule out sexual assault. And if the vulva appears to be normal, then you need to examine the child in a knee chest position. And then if you find any abnormality in a knee chest position, you are going to assess intravaginal and check for trauma and check for a foreign body or a tumor. And if you don't find anything on a knee chest position, then you are going to look for a Shigella species or strep A on a culture. So you take a culture specimen and send it to the lab. Then the two commonest causes of bleeding in that age group is the Shigella and group A strep. So if that is confirmed, you definitely will treat this patient with antibiotics, reassure the mother, and then you complete the course. And if you can't find any of those and there are signs of estrogen stimulation, like breast development greater than 10 or 2, you check the age of the patient. If it's appropriate for age, and then you treat that as the first menstrual period. If it's not appropriate for age, then you classify as precocious puberty, and you look for other things that can predispose the patient to that. However, if you have assessed the patient and there are no signs of estrogen stimulation, you are going to do you are going to do examination under anesthesia. That one, you are going to be looking for trauma, you are looking for foreign body and tumor. If you find that, you treat as that. And if you don't find any of that, that patient must be treated as benign propubertal vaginal bleeding. So that's for children. So like we said, the commonest cause of bleeding in this age group is a vaginal foreign body. So this patient can come to you with or without a discharge. So sometimes the mother can give a history that the patient came from school crying of pain, that they were playing somewhere and then they fell on their buttocks or something like that. You must always look out for a foreign body on such cases. So those ones in that age group, it's always advisable that you do examination under anesthesia. And such age group, you must therefore counsel the mother, give antibiotics after removal in theater, and then you complete the course. When it comes to adolescents and reproductive age group, so this is the most interesting group for which majority of our patients come and see us. The adolescents ones, the main issue there with adolescents is the immaturity of the HPO axis. So that one, most of them will come with abnormal uterine bleed with no any evidence of structural cause. For these ones, they respond very well to combined oral contraceptive. However, for those that will present to you with a history of bleeding tendencies like epistaxis, or they've got ecchymosis when they've got injuries, those ones you must always look for bleeding disorder. The commonest one in that age group is vulvolar factor. So this one's bleeding in their life, it's actually not a good one because it impacts on their quality of life. And most of them will actually avoid public things. It also promote school absenteeism and limitation of social life. They'll also avoid going into public because they are scared that bleeding can just occur at any given time. Maybe they're in the mall having their good time and then the bleeding starts there. And yeah, so this group is the most one that we see. And they say that the rate in this group is higher compared to adults, with 37% versus around 10 to 20%. So in this group, what you do when they present to you, it's always good to take good history. You want history, you want to know if they've had any exogenous estrogens, you want to know if there's any history of use of contraceptives before, And you want to also know if they are sexually active, because they might be coming in with a pregnancy-related bleed. So it is always good to do a thorough history, and then you do examination. Recommendation is that you always use a palm comb as the approach mechanism, because it will give you the causes and also the the commonest cause in this age group, and it will guide you in terms of examination what to do. In this age group, commonly ovarian dysfunction or ovulatory dysfunction is the most presenting issue because of the immaturity of the HPO axis, like I've already said. And this group, they respond very, very well with contraceptives. And then moving on to reproductive age group, which is 15 to 49 according to WHO. The prevalence among these reproductive age women internationally is estimated to be between 3 to 30%, with a higher incidence occurring around menarche and perimenopausal age. And in terms of the reason why that is happening is because with the perimenopausal group, there is a transitional phase where there is diminishing of ovarian function, and then you end up with unopposed estrogen, and then most of them come up or present to us with hyperplasia. And then in terms of the younger ones, or the ones that are that menarche had just started, is mainly because of what I've already said of the immaturity of the HPO axis. So in the reproductive age group, the commonest cause there is structural causes, which structural causes are in the uterus. So how do you therefore evaluate the uterus? So this next diagram is going to just guide us in terms of uterine evaluation in patients with abnormal uterine bleed. So you risk classify the patient. Is it a patient with increased risk of hyperplasia or neoplasm or both? These are patients with increased BMI, patients with PCOS, patients with family history of cancers, and so on. So if that is the case, these are patients that will benefit from an office biopsy. The gold standard here is actually a hysteroscope, where it's a goal-directed biopsy. And if you have an adequate specimen from that, it will tell you what you are dealing with. Is it a typical hyperplasia? Is it cancer? If that is the case, you are going to treat accordingly. If it's none of those, you are going to presume that this is abnormal uterine bleed due to ovulatory dysfunction. So if it's a patient that has an enhanced or increased risk of structural abnormality, the first thing you want to do, the first thing you want to do for that patient is a transvaginal ultrasound. On the transvaginal ultrasound, you are going to assess the cavity. If they've got a normal cavity, you are going to treat that patient as abnormal uterine bleed. We presume that it's a ovulatory dysfunction and manage as such. If the cavity is not normal, this is a patient that can benefit for a saline infusion sonograph that will actually show you what you are dealing with, and you can do a target biopsy and have a diagnosis and treat as such. Or you can do a hysteroscopy with a target biopsy, and then you treat as such. However, if any of these cannot yield anything on a patient who's of reproductive age, and you can't get the diagnosis, it is wise to do a MRI that can actually evaluate the uterine and the structural causes of uterine bleed in such a patient. So this picture basically just shows us the commonest causes, like I said, structural causes of abnormal uterine bleed. on a reproductive age patient. And there's imaging that we can see on the picture A and B, which are showing how a polyp will look like on a ultrasound view and also on hysteroscopic view on picture A and B. So if that is the case, you are going to confirm with a biopsy and then manage as such. Picture C and D, they just show adenomyosis on an MRI and also on an ultrasound. So there are features of adenomyosis that we look for. It happens that adenomyosis is one of the commonest cause of abnormal uterine bleed that is underdiagnosed, and it's mainly because we do not look at those features of adenomyosis on an ultrasound. So if we can just invest on looking at those features, and maybe we can pick up most of them and treat according, because they do very well with just intrauterine device like a Mirena, which is the first line treatment for such patient. And then picture F and G, they are just showing what you can find on a patient with a uterine cancer on a histological specimen and also just after the operation itself. And the ones on the right is non-structural causes, whereby they are just showing that on ovulatory causes, you can see things like PCOS as the cause of abnormal uterine bleed. You can have iatrogenic causes like use of an IUCD as a cause of abnormal uterine bleed. So the perimenopausal group, this group, like I've already said, is that they are in the transitional phase. So there is a decline in ovarian function in this group. So they can present with abnormal uterine bleed because of that. This study was done by Gazala et al. They actually looked at 184 hysterectomy specimens of patients that presented with abnormal uterine bleed in the perimenopausal group. So this was between 2010 and 2011 December. So it was a period of 24 months from January to December. So they actually find that the commonest cause of abnormal uterine bleed in this group is adenomyosis. Like I've already said, we are underdiagnosing it, and it's very, very common. So we need to look out for those features so that we can treat our patient accordingly. The postmenopausal group, postmenopausal period, it's patients that will actually have more than 12 months of amenorrhea and now presenting with abnormal bleed. So the incidence of bleeding in this group is about 10%. And of that 10% incident of postmenopausal bleed, 10 to 15% are said to be endometrial carcinoma, with 40% being endometrial polyps and hyperplasia. So a patient that will present with postmenopausal bleed, you must always attribute that to intrauterine source. And the most important part on this group, ladies and gentlemen, this group, if you've got a patient that comes with bleeding, you must always think cancer until otherwise proven otherwise. So in terms of the etiology, there are so many differential causes of postmenopausal bleed. The commonest one, as we can see, is atrophic vaginitis, with about 59% of patients who present in that age group having atrophic vaginitis. Our main interest there is about 10% who will present with endometrial cancer. If we can just rule out endometrial cancer in this age group, I think we will be doing well. And then 10% also can be as a result of endometrial hyperplasia. So in terms of how you would approach them, a patient with postmenopausal bleed coming to you, normal cervix, normal cervical smear, normal vagina on speculum. So you need to take history and look at the patient characteristics, whether they are it's predicting whether it's a malignancy or not. So you are going to assess endometrial thickness in this patient. If the thickness is less than 4 millimeters, you're still going to look at the risk factors, whether it's this a patient who's a non-HRT user, are they having an irregular ET or is just a smooth ET? Is there any fluid in that cavity? If there is, this is a patient that you need to consider a biopsy. Office hysterectomy is very, very important on this group. If they don't have any risk factors, there is really no need to do much for them. You can just reassure the patient and then reinvestigate if the bleeding reoccurs. And if you've got a patient of this group with an ET more than 4 millimeters, this one is always good and important to rule out CA endometrium. So these are the patients that you're going to do office hysteroscopy or endometrial sampling. Office hysteroscopy is the most reliable and the most advocated mode of investigations in this group because you're going to do a direct biopsy on the abnormality that you can see compared to a blind endometrial sampling. And if you've got a sufficient sample, it is going to tell you whether you're dealing with malignancy or is an hyperplasia, and you're going to manage as such. And then if there is no evidence of, if there's evidence or if it confirms atrophy, you are going to wait for a rebleed and manage as such. Then you're going to redo the whole investigation again if they bleed. Okay, so postmenopausal group, this is exactly what we just went through. Its history is very important, and examination. Part of an examination include a PVPR exam and also a speculum examination. So in this group, you want to rule out any lesion in the vagina, in the cervix, and then you are going to also do a sonar to confirm the ET. And then in terms of investigation, a pap smear is very important because it will guide you. If you've got any abnormalities in pap smear, you can manage that first before you can take a further step. However, a gold standard for these patients is office hysteroscope and a direct biopsy to find the cause of bleed. Yes, this is just what I've just said. This one will tell you if you're dealing with a benign condition or is a malignant condition. And if it's a malignant condition, these are the patients that needs to be sent to the oncologists who are going to do such an operation. And if it's a benign condition and the patient doesn't bleed or doesn't need any other thing, these are patients that you can observe and then reassure the patient. However, if they continue bleeding to such a point that now it's symptomatic, these are the patients that you might end up with a hysterectomy. So in terms of take-home message on this, we need to consider or we need to focus on RCOG and ECOG guidelines with WHO in terms of management of patients that come with abnormal uterine bleed, and use palm coin as a classification because that is going to help us to classify the patient, to ask relevant questions, relevant history, and look for probable things that we can treat. However, in the patients that are of reproductive age, it is very, very crucial that we do a pregnancy test to rule that out. And then when do you therefore decide to refer a patient? So in terms of referring or referral of a patient, it is good to refer a patient earlier than late, so that if there is need to do any timeous intervention, it is done on time. So patients that come with hemodynamic instability, they need to be referred to for assessment. Those that have risk factors of cancer needs to be referred for assessment. And the patients that will present with first episode of bleed, it's always a good idea for a gynae to have a look and then make sure that it's not something that will need any intervention earlier. If it's a patient that can be treated at a lower level, then that can be done. If the treatment needs to be escalated, it will be done timeously on time so that we can help our patients. Just to mention one thing in terms of the new things, there is new evidence that came in 2025. There was a study that has been done by the European Journal of Obstetrics and Gynae. They wanted to look at the risk factors of endometrial hyperplasia and cancer for patients that are lower than 40 years, because we know that those patients that come with abnormal uterine bleed and they are lower than that years, we don't usually look at cancer as the cause. So there is a new study that says if you have such patients with increased risk factors for endometrial cancer or hyperplasia, they need to have a biopsy compared to what used to be the thing that you'll do a biopsy after the age of 45. So a patient with high BMI, nulliparous patient, endometrial thickness of above 15 millimeters or 1.5 centimeters on sonar, those that have cystic spaces on endometrium, they need to be sent for a office hysteroscope and biopsy to rule out hyperplasia and cancer on such patients so that intervention can be done earlier than later. And ladies and gentlemen, thank you very much for your attention. That was what I had for you this evening. Thank you.
Thank you very much, Dr. Maluleka. That was an amazing lecture. I think personally I learned a lot. I hope that our audience of 649 people learned just as much, probably more than I did. I think this was a mouthful, and I think you won't repeat what you said, but people will, lots of things to take home. I think you had a slide saying take home. I think there's a lot today to take home. Thank you very much. You see a lot of applauses on the screen, and I think they're genuine appreciation of the lecture that they've just heard. We are now open for questions and comments, by the way. Dr. Maluleka will respond to your questions and answers questions, and those who would like to type them in the chat box may do so. We'll attend to them as many as possible within the time we've got. Those who would like to raise your hands, and I think I see already a number of hands, please do raise your hands, and we will come to them, and then our team in the background at Telakele and others will allow you to be able to unmute yourself so that you can put your question orally. Let's start with Sindiswa. Sindiswa, you can go ahead. Telakele, if you can allow Sindiswa to unmute and ask her question. Sindiswa, you can go ahead. Is she having a problem? Telakele, are you assisting? Telakele, can you answer, please? Sam?
Tekinoshi?
Yeah, please assist people to unmute themselves. Let's start with Cindy Swan, then we'll come to Professor Dirk Du Plessis. All right, if Cindy Swan is having a problem, let's go to Prof. Dirk Du Plessis. Prof, you can go ahead and put your question.
Hi there. Thank you, Dr. Karashi. Dr. Maluleka, thanks for the presentation. It has enlightened me a bit to think back about my earlier years. But what I just wanted to emphasize, a lot of people currently, especially in the older group, on some form of anticoagulation medication. In other words, just warfarin. It's quite a common thing. Atrial fibrillation is quite a common occurrence currently in our, especially older population. And in addition to that, that's now particularly my field of interest. If you talk about heart valve replacements, then they're on warfarin, the majority of our people. Our people, the majority being of a much younger age group than the standardized first world stuff that we read about that get bioprosthetic valves. So the thing is, I think it is a common thing to watch out for because someone might not necessarily give a proper history. If you don't pull it out of them, then they might only tell part of the story. And then unfortunately, there's also the common response. Sorry for me just going on and on a little bit. There's also the unfortunate response by medical practitioners, sort of broadly speaking, to say if someone is over warfarinized, then there's a knee-jerk response to give them vitamin K, which effectively is then killing the patient, which is very unfortunate. So we do have a fair number of yearly deaths caused by well-intentioned medical practitioners. In other words, vitamin K in the presence of a heart valve. So please, can we just make sure that when you go through all the checks and balances and you check the history and you find out they are on warfarin and they say, oh, you're bleeding a bit and okay, you're over warfarinized, let's give you vitamin K. Please make sure that they do not have a heart valve in place because it is death if you do that. Thanks, Ed.
Thank you very much. I didn't, Prof, for those who don't know, Prof. Derek Du Plessis is a renowned cardiothoracic surgeon himself, and I didn't know that cardiothoracic surgeons can have a gynecological obstetric questions. That's interesting, Prof. Dr. Maluleka, would you like to respond to Prof?
I think what Prof has said is very, very important. It goes back to history taking. So history taking will definitely include history of medical condition, history of drugs. So for patients that are on anticoagulants, yes, it is one of those commonest presentation also. So we need to explore that part when it comes to abnormal uterine bleed. So yes, I agree with what Prof has said. I just didn't get the very last part of his comment.
Okay. Yeah. If Prof is on the line, you can maybe repeat what you said.
Repeat it in what part?
The last part of what you. Yeah.
Oh, you mean in terms of vitamin K usage?
Yes.
Are you talking about that? Oh, no. There's like I said, there's the unfortunate thing, and I must add it is now mostly prevalent amongst people working in your mouth, teeth. There's also the occurrence in amongst your profession that you work in. To give this knee-jerk response of quinacridone. In other words, I always ask the question, what is the dosage of vitamin K that you give to someone if you want to reverse a particular effect? Now, if you understand how warfarin works, then you immediately come to the conclusion, well, if you think about it, baby is born, let's give mom an ampule of vitamin K, quinacridone. Oh, and let's give baby a nice shot as well, and give everyone a shot. And the trouble is, there isn't actually a proper dosage because it's one of the fat-soluble vitamins. So in other words, you are effectively always completely, massively overdosing someone with vitamin K when you give it. And now that disturbs the entire mechanism of how warfarin works. So the patient is not going to die that day, the next, or the next, but he'll die on day 4.
Yes.
After you've given it. That's the trouble. So that was by that time you might have even discharged the patient. And then you say, oh, no, it's God's will, that you died at home and all that. Obviously, I didn't have anything to do with that. But as a matter of fact, the good intentions of the doctor created that scenario.
Yes, yes.
So,
Yes,
Yeah.
Prof.
Thank you very much, Prof, for bringing that up. And actually, I see in the chat quite a number of people have written about looking out for anticoagulants whenever there's bleeding anywhere in on the body. And thanks very much. I think Dr. Becky Hadebe also wrote about it in this thing. Let's just go to other questions. There is a question. Well, this one I think is an easy one. Can a surgeon treat and manage a vaginal tumor or Bartholin's abscess, or is it an area limited to gynecologists? I think this one you can dispense with quickly, Dr. Maluleka.
Yeah,
Maybe there's a reason
I think
why
it's actually just the same
Dr.
way.
Hadebe asked. Maybe there's a reason why Dr. Hadebe asked that question.
Yeah, I think it's the very same way that a gynae can treat perianal abscess. So I think it's a gynecological issue, so let gynaes deal with it.
Yeah. Yeah, when
Yes.
it comes to CA, one can say so, but when the Bartholin's abscess, I know a lot of people in GP treat that on a regular basis. I think anyone can treat, any doctor.
Oh, okay. Yeah, in terms of
Your
that.
comments?
Oh, I thought he was referring to other specialists treating Bartholin abscess. However,
Yeah, okay, no, that's fine.
even GPs can treat a Bartholin abscess. Yes, true.
That's
Yeah.
fine. Thank you very much. I think there's a question from there's a question about the term adenomyosis. Is it same as say myoma or fibroid?
It is not the same. Adenomyosis, however, the presentation is almost the same. Adenomyosis is it's those long-term effects of reverse menstruation. So when the patient see their normal periods, a smaller part of blood will go into the myometrium, and that builds up over time. And then when they are in the perimenopausal period, that's when they start to come up with to present with bleeding. Whereas with a myoma, it's a benign a tumor of the myometrium. So there is that difference.
All right. Yeah, it's quite a number of questions, so we'll try to go through them first. I think it's Faith Chando saying that, and it won't be maybe in the order that they came, and I apologize for that. Good evening, Dr. Maluleka. If I may ask, if one had a hysterectomy in 1999, just before the year 2000, when she was 25, that was when she was 25, in 2026, she is presenting with, so she's about now 50, 61? In 26, 25 plus 26, it's 51. When she presents in 2026, that is this year, with uterine bleeding, with lots of clots, could that be malignancy at the age of 51?
It's
And
very highly possible.
Yeah, I had a
Yes,
hysterectomy at the age of 25.
It's very highly possible. I think that's the patient that needs to be assessed by gynae. We need to do a speculum examination and assess if there's no vault mass there, because she could be bleeding from a vault mass. So we need to do a speculum for that one to rule out malignancy.
Yeah. Okay. I think there's a comment from Prof. Yasmin. Prof. Yasmin, Professor Yasmin, Adam, you can unmute yourself and put your question orally, please. I think you are a co-host, where you talk about that you're agreeing on the cutoff when you do an ES. Maybe you can make your comment orally, please. Yeah.
Okay. Good evening, everyone, and thank you, Dr. Maluleka. I agree with you that you used to use the cutoff of 40, and then well, 45 and then 40, where you would do an endometrial sample if there was abnormal bleeding. And you said that if the endometrial thickness was greater than 1.5. So then my question to you is, if it's less than 1.5, would you leave the patient? Would you just reassure the patient?
I think if it's less than that, you look at other factors. So is it a patient that has high BMI? Is it a patient with diabetes? Because you know that those are the patients that have increased risk of malignancy. So if there's other factors with other sonographic features, like you see cysts in that endometrial cavity, I would definitely go ahead and do a biopsy for that patient.
Thank you.
Mm-hmm. Hello? Hello? Can anybody hear me?
We can
Hi,
hear
Doc.
you.
We can hear you, Doc.
Oh,
I think
okay.
Dr. Kinos is just having an issue with his connection, but he should be back now.
Okay.
Dr. Kinos, are you good?
Yeah, ask Dr. Burton to take over the next question. Can you hear me?
We can hear
Yes,
you,
we can
Doc.
hear you,
Yes,
Doc.
I can hear you from my side.
Thank you. Yeah, there's a question from Dr. Mutlante about office hysterectomy or in theater, in hospital or in theater. Whether is it a monetary issue? That's what he asked.
Okay, so in a well-resourced space, it is good it's hysteroscopy that you can do as an office outpatient procedure or in theater. That will give better results because you are going to biopsy a tumor that you can see or an abnormality that you can see. So if that biopsy comes out and says negative, no tumor, then you are sure that there is no tumor on that patient. However, with an endometrial sample, you can just take a sample from where there is normal tissue and the patient will still continue to have symptoms or even get worse in terms of if it's cancer, it can also get worse before we can intervene in cases of cancer and the likes. Any more questions?
I think, okay, Doctor, if you can hear me, Dr. Shinas will do the next few questions. But I think maybe the last one from me. Somebody says, what about bleeding from NOACs?
Bleeding from?
NOACs. I think I'm not sure. I'm not familiar myself with the abbreviation.
Oh, not otherwise specified.
Oh,
Yes. So if it's bleeding from not otherwise specified,
are people so pressed for time now these days that they don't write out?
yes. So bleeding from not otherwise specified is as it explains it. You have looked for all structural causes. You didn't find anything. There is nothing that points towards non-structural causes. So if you can classify the bleed for the patient, you treat it as a not otherwise specified.
All right, Dr. Shinas, you can come in.
Yes, good evening, colleagues. Thank you, Dr.
Dr. Shinas, just to say, Dr. Shinas, at the end, I'd spoken to Professor Yasmin Adam, to do the vote of thanks at the end.
Yeah, I appreciate it. Thank you so much, Dr. Kinoshi. Again, colleagues, good evening, and thank you so much for joining us on another Thursday, where Clinix Healthcare Group is presenting the webinars. Dr. Maluleka, Dr. Kinoshi is absolutely correct. You are a gentleman, and it is a pleasure getting to know you this year alongside your wife, who I am afraid is becoming increasingly more popular than you. So we're looking forward to to hearing from her soon. She can join us soon. So, Dr. Maluleka, some questions I'm sure that you can deal with quite easily. One of them is, what's the difference between hysteroscopy and hospital hysteroscopy? Is it got to do with monetary terms, or is there any other way that one can do it? So in either office hysteroscopy or in the hospital?
I think office hysteroscopy, the procedure is basically almost the same. If you've got the resources, it's always best for the patient to do office hysteroscope. But if you don't have resources, obviously you're going to use hospital resources, which is done in theater. In terms of difference, it doesn't yield any much difference. The result will still be the same. If the patient has got cancer, you'll be able to get the diagnosis, whether you do an office hysteroscope or in theater. If the patient has got a polyp, you'll be able to diagnose that. So it does not really have much of difference. It's just a matter of resources.
Okay, so a matter of resources. Okay, yeah, because the question was, did it have something to do with finances? So, but thanks for clarifying that. And then obviously you heard from Professor Adams, who put forward the thickness in the endometrium question. And then it just talks here about the question is, thank you for the presentation. And I saw many people putting their hands up and applauding you. Thanks, Dr. Maluleka. Says here, my late mother had recurrent postmenopausal bleeding just before she was diagnosed with stage 4 renal cancer. What could have been the correlation between the two? That is renal malignancy and vaginal bleeding.
What I know is that patients with renal failure, depending on where what the cause is, rather not depending on where the cause is, if they've got very high urea, they can present with bleeding. So I think maybe it was missed because of that. They can present with PV bleeding because of high urea.
Yeah, thanks for that, Dr. So I'm seeing Dr. Kinoshi on the screen here. So, Dr. Maluleka, so there's an interesting question here, and I think you touched on it in part. The question is, can you still have cancer even if you've done a hysterectomy? You talked earlier on about vault as an example where you said you may need to clarify that by inserting a scope, or at least doing an inspection to make sure there's no mass in the vault. But is there any other reason why one would be having a malignancy risk even if you've had a hysterectomy done?
If a patient has had a hysterectomy done and at the point they had HPV infection, or even if it's as a new infection, HPV is not good for the pelvis. So for women, that's why we advocate HPV screening always. So if that's the case, yes, you can present with a vault mass after some time of having a hysterectomy as a result of HPV infection.
Okay. Yeah, so thank you for clarifying that, Dr. Maluleka. So I've got a few questions here. Is there any measures in place to correct or combat the initiation of COC to control AUB without investigating at primary healthcare level? Going to what Dr. Kinoshi says with the abbreviations. Did you follow that?
Yes, I think I also touched on that earlier on. It will be a very good idea to send a patient for at least a gynae assessment if they present with the first episode of bleeding, so that we can avoid giving COCs even for patients that don't need COCs. So early assessment by gynae will actually be very helpful in that regard.
Thank you so much, Doc. And you said earlier referrals are better than late referrals when you are having doubts or you are looking to get some clarity with regards to management of patients.
Yes.
Is this, yeah. So especially the younger patients, Dr. Maluleka, or do you find that across all age groups?
Interesting enough, in the older age, yes,
Yeah.
they are sending them earlier, which is good. So we should continue doing that. But I think even for it cuts across all the age group. Let them have a gynae assessment, and then if nothing it's alarming, then they can continue with COCs as the first line of treatment, especially for the ovulatory dysfunction group, which is the vast majority of the patients, by the way.
Yeah. Thanks for that, Dr. Maluleka. Yeah, I know Prof. Adam is going to be giving us a vote of thanks. So before that, maybe just two more questions. So here's a question. Hi, are the fibroids hereditary or not? Are they genetically possible for one to be in high risk or have one? Is there some form of genetic link between having fibroids or not?
Yes, there is a very strong connection between hereditary component when it comes to fibroids. So yes, some of them, they will run in the families. It is wise to check if you've got abnormal bleed and you know that your sister or your mother has got fibroids, confirmed fibroids. So it will always be a nice idea or a good idea for one to check also if it's not the case.
Is it possible that during surgery, I take it this is after hysterectomy, I'm taking a question here from Chiamo Popong, who could possibly clarify, but the question is, could it also be because of cells not entirely removed during surgery? It says, yeah, I know radiation is normally given as a way to prevent cancer from developing after surgery. So the question is really, is it possibly due to some cells that were missed?
Is this about a patient with a confirmed cancer on biopsy? Or is a patient that will go on to develop cancer later on in life?
Do you want to perhaps give us the two perspectives, Dr. Maluleka?
Okay, so this is the reason why assessment is very important. You need to assess a patient and stage them properly before they can have an intervention. If it's a cancer patient, it is best if they're treated by a gynae oncologist, not just a general gynae. Yes, it is possible that some of the cells can remain, and then, which is the reason why you've got chemoradiation after staging laparotomies or cancer surgery. Is for mainly for that reason. So when we do a cancer patient, we look at the histology. Histology will tell us if the tumor was completely excised or not. So if histology doesn't confirm that the tumor was completely excised, it is always a good idea that the patient goes for chemoradiation to cover that part.
Thank you so much, Dr. Maluleka. We as we draw to a close this evening, I just want to remind our colleagues that next week we'll be having a presentation on point of care diagnostics, and this is by Prof. Tivani Mashamba Thompson from the University of Pretoria, who's a director and does extensive research in this environment and in this space. So we look forward to you attending next week and joining us, inviting Professor Mashamba Thompson. I'm sure there's going to be a significant amount of knowledge shared with all of us. Professor Adam, if you are ready, please feel free to join us and look at closing this evening. Thank you.
Um, Dr. Maluleka, thank you so much. I think that I learn all the time, and it gives me great pleasure to thank you as a fellow gynecologist for this very important and common topic. And as you can see, it's important, and for all the people here, specialists, other health workers, pharmacists. And I think the way that you did it, the approach was great, because when you divide it into those groups, it makes it easier when you've got a patient within a group. And in medicine, common things happen commonly. So when you divided it into ages, it brought the commonness for each of the different, for all of the ages. So, and then to say thank you to the audience, because I think the questions are the most important part of the talk, because it's all the issues that you've had in practice that you can have an expert answer for you. So thank you to the audience as always. And a really big thank you to Clinix for these wonderful webinars. I think that I learn something every Thursday. And then, of course, to the people behind the scenes who make this happen. So thank you, Dr. Shinners, and thank you, Dr. Kinoshi. And a big thank you, Dr. Maluleka.
Excellent.
Prof.
Thank you, Professor Adam. Look forward to joining again. Professor Adam is being humble. She's also involved in assisting as a clinical risk committee member in the Clinix Health Group. So thank you very much for your constant contribution and always being available to teach, educate, and make valuable contributions there. So thank you to you, Professor Adam. So ladies and gentlemen, thank you once more. We look forward to joining you again next week, Thursday, as Clinix Health Group webinars will be ready to bring to you another presentation. And we look forward to seeing you there. Have a good evening, everyone. Thank you.